welcome to ITU Cork's webinar on COVID-19. We truly are in unprecedented times. So we're going to look this morning at some exponential growth and flattening that curve that everybody is hearing about. We'll also look at how the tech sector is responding. We are expecting over 400 attendees at this. We're currently at about 207, but in the interest of time, I do want to get things started. So my name is Gillian Bergen. I work at Dell Technologies, and as Vice Chair of ITU Cork, it's my pleasure to welcome you all this morning to this information session. A small few pieces of information so you can get the most from the event. The session is being recorded, so we will make that available to everybody afterwards in the coming days via social media. And during the event, there will be some polls that pop up. We're just interested in getting your opinion and your thoughts on a number of things. These will pop up every so often. We do encourage you to have an opinion and to fill it out very, very quickly if you can. Owen, if you could bring one of those on screen now so that folks can get a sample. And there we go. If folks would like to vote, then we can get that sample done. And there'll be a few of those pop up here and there throughout the call. Again, that will be made available on social media next week so that you can see the results of those surveys. There will be an opportunity later on to ask some questions of the panel. We'll let you know when that is, and then we will use the Q&A function of this webinar to do that. There will also be a 2-question survey at the very end of the event. It's literally, was this event useful, and would you like to see more of them? So we'd love you to take part in that as well. Okay, time is of the essence, and we have a lot to get through. So without further ado, I'd like to ask each of our panelists to introduce themselves very quickly in about 30 seconds, who they are and what they do before we get into the main updates and the Q&A. Okay, so Professor O'Leary, can I invite you to just introduce yourself to the team, please?
Good morning, everyone. My name is John O'Leary. I'm a clinician scientist working in Dublin. I'm the Chair of Pathology at Trinity College Dublin. I'm a consultant pathologist at St. James's Hospital and the Coombe and Infants University Hospital. I'm the Scientific Director of the Trinity St. James's Cancer Institute.
Brilliant. Thanks, Professor O'Leary. And now, Professor Carney, could I invite you to do the same?
Hello, my name is Patricia Carney, and I'm a Professor of Epidemiology in the School of Public Health in University College Cork. In ordinary times, I'm a cardiovascular epidemiologist and clinical trialist, and so mainly work in chronic disease. But of course, these are extraordinary times, and for the past 3 weeks, I've been seconded to the health service to work in public health, and we're going to talk more about that later.
Thanks, Professor Carney. Extraordinary times indeed. Dr. Hogan, can I invite you to do the same?
Hi, my name is Martin Hogan. I'm an occupational physician, which means practicing medicine in the workplace. I've been nearly 30 years in occupational medicine. I'm a past dean of the Faculty of Occupational Medicine of the Royal College of Physicians of Ireland, and I'm Managing Director of Corporate Health Ireland in Cork.
Great, thanks, Martin. And Karen Egan, if I could invite you now as well.
Good morning, everyone. My name is Karen Egan, and I'm a Vice President for both Global Support and Customer Success at VMware. I've worked in the tech industry for over 26 years now, and as well as that, I'm also one of the site leaders for our VMware Ireland campus here in Cork.
Super, thanks, Karen. And last but not least, if I could invite Jerry Sweeney to do the same.
Hello, my name is Jerry Sweeney. I'm the Managing Director of Cork Internet Exchange, and I'm a Director of INEX Ireland as well.
Lovely. Thanks, Jerry. And before we go any further, a huge thank you to our panel. I know they're extremely busy. They're taking time out this morning to share information with us, so we are extremely grateful. There's serious expertise and knowledge on this panel, so our sincere thanks to them, and we're looking forward to some expertise and advice and finding out ways how we can help in these extraordinary times. So the format from here will be each of the panelists will speak for a few minutes on their area of expertise. We're going to see some powerful data. We're going to see and hear from our experts with personal and professional advice, and then we'll move into a panel discussion, and then slightly after that we'll open up to the floor for questions from the audience. So without further ado, I am going to hand now to Professor O'Leary, who has a few slides to go through, and he'll spend 8 or 10 minutes bringing us up to speed on all things COVID-19.
Okay, good morning. Good morning, everybody. So we are in the middle of a crisis, and this is probably one of the greatest battles we're going to face in our lifetimes. I have over 30 years experience working with viruses. And today I want to share some of my thoughts with you. Shane, can we? So the title of my presentation is Targeting COVID-19. So we're all very well aware of the coronavirus COVID-19 signs that the HSE have put out. I think the HSE have done an absolutely excellent job. I think the most important thing now is that we need to understand that we need to reduce our social interactions, keep a distance from people of at least 2 meters, and do not shake hands, and use good hand washing techniques and sanitary techniques to fight the spread of this disease. There are some issues, though, however, to be considered in relation to COVID-19. Clearly, we know what the causative agent is. So this is a coronavirus. This is related to the SARS virus and to the MERS virus. And it has a altered spike protein that makes it much more likely to enter into human epithelial cells, particularly in the upper airways and upper digestive system. As well as the causative agent, we need to understand what's meant by the susceptible host. So some people are more susceptible to getting this disease, such as people who've got cardiac disease, respiratory disease, diabetes, or who are immunocompromised. The portal of entry is usually the upper airways, but can enter through the eyes. The mode of transmission is by droplet infection. The portal of exit, again, is through the mouth and nose, again by droplet infection. And the reservoir essentially now is in us humans because it has infected so many of us. The common symptoms are fever, dry cough, and fatigue. And I think over the last number of days, we have been advised to tell patients that running eyes and an altered taste sensation or smell sensation is also probably a prodromal sign of the disease. But you can see here listed there are uncommon symptoms, and in severe disease, patients have an extremely high fever. They're coughing up blood in some cases, their white blood cells are decreased, and they develop multi-organ failure, usually manifested through kidney failure. I think we're all pretty familiar with this curve, which is really about trying to explain and define how we can lower and delay the epidemic peak. If we did nothing, you can see that you've got a situation called uncontrolled transmission, where cases will rise and rise and rise and rise, and then will start to fall as immunity or herd immunity in the population develops. That's clearly not a situation that we want to develop. So the government here and all over the world have introduced control measures to slow the spread of the disease and reduce the burden on hospitals. I just want to give you some figures that the WHO released yesterday. It took 67 days from the first case of this disease, COVID-19, until 100,000 cases were identified. For the next 100,000 cases, it took 11 days. And for the third group of 100,000 cases, it only took 4 days. So this is a rapidly spreading infection that, as you can see, is having major global consequences. This is the COVID-19 map from the WHO on the 18th of March, and you can see that the epicenter of the disease had changed from China and Asia into Europe. And yesterday, the Center for Systems Science and Engineering at Johns Hopkins University, this has a real-time plot of the number of cases, the total confirmed cases, the total number of deaths, and the total number of people that recover from the disease. And I'd advise you to go on and look at this, but you can see that Europe is essentially at the center of this, and the United States is also becoming a very, very dominant area for COVID-19 biology. This is a new virus, and clearly this is a new outbreak at a pandemic level. And this demands a new set of tools to be applied in terms of trying to understand the disease and trying to stop its spread. This is called outbreak analytics, where we use molecular technologies and look at molecular epidemiology. We look at transmission rates. We look at geographical maps of where the disease is. We do contact visualization. We look at the phylogenetics of the virus to see is it mutating. And then there's a whole lot of computational models that we use to identify what exactly is happening with the disease. This is from our colleagues at Imperial College COVID-19 response team in London. And here, this is the current estimate of the severity of cases going from 0 to 9 right up to 80 years plus. You can see that the percentage of symptomatic cases requiring hospitalization increases as you get older. The percentage of hospitalized cases requiring critical care increases as you get older. And the infection fatality rate also increases as you get older. We don't know really now what the overall fatality rate from this infection is, but it's probably in the range of 2 to 3%. If we do nothing, which is called an unmitigated epidemic, these are scenarios, again, from the Imperial College COVID-19 response team in terms of what's going to happen in the United States and in the United Kingdom. And of course, we can deduce from these figures what potentially could happen in the Republic of Ireland. If we did nothing, in the United States, 2.2 million people could die over the period of March to August 2020. In the United Kingdom, this could be as high as 510,000, essentially wiping out a small city. The bottom graph, panel B, shows mathematical modeling in terms of the outbreak of the disease as expressed as cases per 100,000 of the population in the United States. And clearly, these are just mathematical models which are stylized on what we know right now, and these could fundamentally change as we go forward. Our colleagues, again, from Imperial College have looked at the effect of mitigation strategies over a defined window here indicated in blue. And I'm not going to go through the various scenarios that are suggested. But as you can see, if we do nothing, we will have a large number of cases. And given what we're doing right now, which is a combination of all of the other potential mitigation strategies, you can see that we're attempting to try and decrease the size or the amplitude of these curves, i.e. the number of cases, and to increase the rapidity of the decreases in terms of the number of new infections. So right now, this is again a mathematical model. It stylizes the data that we currently have. And as you can see, this crisis in the Northern Hemisphere is going to be running from March 20th until around August 20. But what I have to say here is that this is a mathematical model, and essentially any policy in relation to mitigation strategies and disease clearance will be driven by national governments. I can tell you that the Singapore government has produced a very, very similar model that overlaps with this data. I've been involved in viral biology, both cancer and non-cancer causing viruses, for the last 30 years. And back in 2017, in July 2017, we published a paper in Nature Communications, which received a lot of international coverage in terms of CNN, etc. And in that, we described a unique biological pathway. So we've been involved, my group have been involved with colleagues from Australia, Stavros Salamides and Douglas Brooks, in relation to RNA viruses in particular. So what we found back in 2017 was that viruses, particularly RNA viruses, use an inherited mutation that we have inherited post-Neanderthals and which animals have, which is a mutation in the toll-like receptor 7 gene. And this, through another molecule called NOX2, activates the production of what are called reactive oxygen species in cells. These are bad actors. Unfortunately, RNA viruses have found a way of exploiting this and are able to switch off RNA immune processing, or the way that our cells actually see these viruses, so that effectively the cells can't eliminate them any longer. We've had 2 papers expeditiously published this month, looking at, I suppose, the fundamental molecular biology of this. And we recently submitted to Nature Unifying Molecular Mechanism for COVID potential therapeutic approaches. Sorry. So this is an RNA virus. It binds to the surface of the cell through a receptor called ACE2. It's internalized into the cell and bioprocessed by a system called endosomes. And these are structures that process our normal molecules. And unfortunately, the virus has found a way to overcome the normal immune processing that occurs in the cells. It switches off the immune processing that would get rid of it, and allows the cell to produce very, very toxic substances that actually damage the cells directly, particularly in the lungs. And that's why this virus in particular is so lethal in its effect. But, you know, there is good news here. There are possible therapeutic approaches. I'm not going to go through all of these. Some of you have heard about these in the media. Chloroquine, the antimalarial drug, could be certainly repurposed, as can be sarilumab, remdesivir, which is an anti-RNA viral agent, which targets the copying system for these viruses, can also be used. And vitamin D certainly seems to be protective in terms of altering the expression of a system called the renin-angiotensin system, RAS, which directly interacts with ACE2, which the virus actually uses. So this virus, through its spikes or its spike proteins, has developed a way of being able to bind very, very strongly to ACE2 on the surface of cells. And this essentially is the problem for us in the context of this particular infection. There is vaccine development going on, and I've listed the various companies that are involved in this, but it is going to take up to a year at least to develop a vaccine that can be used worldwide. This is mainly on the basis of having necessary safety data in relation to the vaccines. I'm glad to report, though, that there are 2 trials open, one in the United States and one in China as we speak, in relation to a vaccine against COVID-19. And finally, possible screening approaches. So at the moment, we are using PCR, the polymerase chain reaction, to detect RNA virus in samples from patients, and that's a very, very good technology. But there are different possible screening approaches. Regeneron announced on Patrick's Day that they've identified hundreds of virus neutralizing antibodies, which are hugely important in terms of being able to neutralize the disease, and they're now trying to move into large-scale manufacture of these as a potential screening technology. And our own group is looking at peptide mapping for COVID-19. We've identified 4 novel peptides or proteins that could be used potentially to detect the virus very, very rapidly. Secondly, to look at the effect of treatment when treatments become available. And thirdly, to develop peptide vaccines. So look, thank you again for listening. I suppose what we're about today really is about delivering tomorrow's medicine today. There is hope here, and we will beat this. So again, apologies for the technical breakdown in the middle of the talk.
Huge thanks, John, and it's great to to see some of those extra symptoms now that they're telling us to look out for, and also even the impact of things like vitamin D. It's great to see some Irish companies as part of the efforts to develop a vaccine. So a huge thank you for that. We're now going to move to Professor Patricia Carney, who's going to talk about contact tracing, which is a huge part in trying to flatten that curve. I do see a couple of questions coming in, but if it's okay with folks, I'm going to hold those questions till the end. So do put them in, listeners, if it works to put it in now while the speaker is speaking, and we will deal with them when we get to the Q&A at the end. So Patricia Carney, over to you. Thank you very much.
Thanks, Jill, and thanks for the opportunity. So I'm going to move from the future that John has been talking about and the very exciting potential therapeutic and preventive options to really the practicalities of what's happening today, and speak a little bit to the experience I've had contact tracing, which is what I've been spending a lot of time doing over the past number of weeks. I'm sure many of you will have seen some of those photographs of various places around Ireland from the weekend, where we saw, despite the efforts that are being made nationally to try and control movements, still large number of people congregating. So I thought it was worth maybe in the first instance just reminding people how coronavirus is spread. And we know that it's spread in sneeze or cough droplets. And so the reason that we're really emphasizing the importance of social distancing, or perhaps better called physical distancing, is that your risk of getting the virus is if you come into close contact with someone who has the virus and is coughing or sneezing. And that's why you will see, if you are out and about, and people sort of literally physically recoiling if they see someone coughing or sneezing. But I think one of the important things, and I saw already that a question had been submitted around this, was that the virus can live for quite some time on surfaces. And so if you touch a surface that someone who has the virus has coughed or sneezed on, you can also pick it up that way. And that's really the reason why we have been emphasizing so much the importance of hand washing. And it seems such a simple intervention, but the reality is that the virus doesn't survive good hand washing. So if you put your hand in contact with a surface, but then you wash your hands before you become in contact with those parts of your body, as John had explained about how the virus can enter the body through the eye, the nose, the mouth, and if you've washed your hands and removed the virus, then you've essentially protected yourself. So what does all that mean from a practical perspective when I'm doing the job of contacting people who have tested positive based on the swab? So one of the things that I go through with people on the phone is to try and determine who is in the household with them and who else they've come in contact with in terms of the workplace. And so I suppose one of the things I wanted to say was, yesterday I was on the phone to 3 new cases that had been diagnosed, and for 2 of them, they had no other contacts other than the people living in their household. Because of the public health interventions that have been introduced and that people have been largely adhering to, and really there was no further travel of the exposure status. So I suppose from my perspective, that was really good news, and I think it's helpful. There's so much anxiety and concern around now that it's good for all of you who have likely dialed in from home to know that the changes that you're making in your life are really having an impact. So in terms of those close contacts, what that really means is the people in your household in the first instance, and then other people that you were in contact with in close, and by that we mean within 2 meters for more than 15 minutes. And so when I speak to somebody, a new case, one of the things that I have to do is determine that list of close contacts. All right. Oh, I don't know how to make it go back. Oh, sorry about this. I'm doing this. Oh yeah, great. Thank you. So one of the things that we've been doing is, there's a lot of terms out there now: social distance, physical distance. One of the reasons I prefer the term physical distance is because it reminds people that they literally have to be at least that 2 meters apart. But the other thing is that we have seen that people have really found innovative ways to maintain our social interactions, whether it's through Skype, FaceTime, whether it's visiting a grandparent but having a physical barrier in between. So I do think that the term physical distance is maybe one that's useful for us all to think about, so that we remember to maintain those social interactions. From a practical perspective, when I speak to a case and close contacts of a case, I need to advise them about the steps they need to take. As a case, so for any of you who have received that call, it's going to be advised to you that you need to isolate at home. And so what that means is that you literally need to stay at home for 14 days since you first developed the symptoms, and you need to have not had any fever for at least 5 days. From a practical perspective, and I know some of you there will be are likely to be cases, or if you're not cases yet, you'll be getting that phone call in the future. There's some things that I think it's worth mentioning, like you can go outside. So if you have a garden, there's no reason not to go outside and get some fresh air and walk around. And if you're in a household with other people, you need to be able to have access to a separate bathroom, and in terms of getting through your daily life, in the kitchen, and using different utensils. And so really trying to have that separation. Similarly, some of you, and many of you, I would say at this point, may have had a call to say that you have had close contact with a case. And so depending whether if that is something maybe that's happened at work and you're now in no longer in contact with that person, what we're doing really is it's like a quarantine. So we're trying to observe to see whether you're going to develop symptoms yourself, and then try and limit any further onward transmission. And so similarly in that instance, it is important to be able to go outside, get some fresh air, but at the same time, really adhere to keeping away from other people. So I thought from a practical perspective, in case any of you get a phone call from me today, I thought I'd go through some of the things and some of the tips that will make life a bit easier for me today, and hopefully will have a kind of a public health impact. So the first thing I would say to you, please, if you have any symptoms, so if you have a cough, if you have a fever, if you're feeling short of breath, but as well as John explained, there are actually quite a number of more unusual symptoms of this sort of lack of smell, and some people are developing more kind of GI symptoms, so nausea, abdominal pain. Please just stay at home if you're not feeling well. Wash your hands, it works. And there's, you know, unbelievable efforts going on now in terms of developing new treatments, new vaccines, really high tech. But at the moment, the most effective treatment or preventive that we have is just washing your hands. So please wash your hands. I've talked already quite a bit about physical distancing, and I think it's important to emphasize that because, of course, these are really difficult times, and it's very important that we do remain engaged and supportive and maintain our social networks in these really difficult, challenging times. Limit your movements, so, you know, try and, if you do have to go out and about, please try and limit that. The other thing I would say to you now is have a plan. So prepare. You may be getting a call to say that you are a case, if you're someone who's been swabbed, or that you've been in contact with a case. And so have a think about how you will manage if you were having to even further restrict your movements for the next 2 weeks, and how you will manage things like your groceries, your work. The other thing I would say to you is to have a list ready in terms of the people. So for those of you who are still having to go out and about to work, have a list of the people that you've been in contact with and have their mobile phone numbers. If you can, know your own GP name and know their number, and have that information ready to hand. If you're somebody, because of the nature of your work, this obviously applies particularly to healthcare workers, where you're still out and about on a daily basis. If you can keep a note of the people that you're being in contact with, that sort of information, and having that information ready to hand when you do take the call is really helpful. So hopefully some of those tips will help you. Thanks.
Thanks, Patricia. Yeah, absolutely, very helpful. You know, it's great advice to have a plan. Love the idea of this physical distancing, because, you know, we are all social animals at the end of the day, and I guess the message here is we can still be very social, but from a distance. So that's really, really important. And I'm sure you're getting a complex these days when everyone is saying, I don't want to hear from you today. Professor Carney, I'm sure everyone on the phone doesn't want to hear from you today, but just in case we do hear, let's have some of those contacts available. Let's look at and keep a list of people we meet and are in contact with every day and where we go, so that it does make that process easier for you. Okay, so thank you for that. We're now moving to Dr. Martin Hogan. I know, Martin, you don't have slides, so we're just going to leave up this one that's on screen right now. And you're going to talk about the effects this is having in the workplace. So over to you.
Okay, thanks very much. Yes, I mean, there is a big drive from people to work from home, and I suppose I very much support that. And obviously that removes a lot of the risks, but some people can't work from home. And I suppose a lot of what I'm saying today are questions we are getting in relation to people who can't work from home and have to go to work. I suppose I want to echo, it's not the first thing I want people asking. We're saying physical and social distancing from people, avoiding close contacts is hugely important. People should try to anticipate this in advance. They should employers should try to make sure there is at least 2 meters between employees when at all possible. I echo Patricia's definitions of close contacts. The one other close contact that may be relevant in the workplace, if somebody is in an enclosed room for over 2 hours, even if they're more than 2 meters apart. Now that warrants risk assessment, because you can consider the size of the room, ventilation, and the distance apart, but it's something just to consider as well. What a lot of employers are doing now, and I think it's a good idea, is ask every employer to create a log of their close contacts during the day. So in other words, at the end of the day, they will list the people during that day who might have fulfilled the definition of a close contact. I think this is two value roles. One, it makes the person think. Ideally, that log should have nobody on it. So, I mean, it makes people think, where are they coming in contact with people? It may even let the employer say, well, why is this happening? Can we avoid it? And secondly, the other advantage is that if they get a call from Patricia or someone in her team, it does make at that part of contact tracing in the workplace a little bit easier anyway. A lot of employers are asking me, well, what if we take temperatures? Should we take temperatures of people coming into work? But there's not a simple answer to this. The most important part of prevention of this is personal responsibility. Each person should act as if they have COVID-19 and that everybody around them has COVID-19. If they act like that, that's the best way of not getting it. People who are ill should not come to work. People who feel they have a temperature should not come to work. People who are going to work probably should take the temperature themselves. The temperatures is a reasonably good indicator of having an infection. Certainly some of the countries who have been most successful in dealing with COVID-19, particularly talking places like Singapore and China now as well, have put quite a bit of emphasis in temperature taking, but it's not an exact science. Firstly, people who have taken antipyretics or paracetamol or aspirin, ibuprofen, it may lower their temperature and may give a false negative. Secondly, temperatures can sometimes spike. So you may get particularly in early phase, a lower temperature. So again, give a false negative. But probably the biggest disadvantage of taking temperatures, it might encourage some people in a behavioral way to say, well, I feel a little bit off, but I go to work, and if my temperature is high, they'll send me home. The emphasis is they'll send me home rather than taking personal responsibility. I think that's the downside in taking temperatures on the way into work. So, I mean, I have slightly mixed views about it. There has been evidence of success in other countries, but it does not replace personal responsibility. The other questions we're getting are in relation to if people can't maintain the social distance, what about a personal protective equipment such as masks or gloves? Now, a lot of people in the workplace are wearing masks and gloves anyway. More often than not, the masks people are wearing prior to all this would be the dust masks, the FFP2, or known in America as N95. They were certified as excluding 95% of all particulate matter. Then the other ones that are sometimes seen are FFP3, which are known in the US as N99. Now, both of these masks are designed for the protection of the wearer from something coming outside. And they were previously, or they are used for protection of particulates or dusts, but they also will filter out droplets. Some of these masks have a little valve in them, and that means that the air coming out from that person isn't filtered at all. So they are very important in healthcare workers, but by and large, they are not recommended in the workplace because, first of all, they don't protect anyone else, and secondly, they may give a false sense of security. And if people wearing PPE, I'm all right, Jack, they may not take the necessary precautions in terms of social or physical distancing and cleaning work surfaces and sanitizing as they go. You see a lot of people wearing gloves, and again, mixed feeling with regards to gloves. A virus can live on gloves just as it can live on hands, perhaps more efficiently. So if gloves they're not a replacement for hand washing and sanitizing, and they should be regularly replaced. They're not in themselves protective. The other area we're getting questions in relation to is vulnerable employees. Now, John was talking about these. Obviously, the elderly, people suffering from chronic diseases, people who have had transplants, people who have, for example, adult cystic fibrosis. There are a lot of groups who may be more vulnerable. A lot of the really vulnerable people are not in the workplace because they've either retired or they're too ill to go to work anyway. But there are people who are at work who have conditions which may make them more vulnerable. I suppose the two are mentioned from the studies would be hypertension and diabetes appear to be one of and cardiovascular diseases in general. I think the advice there will be on a case-by-case basis, and we'll make an assessment. And I think particularly this will be relevant if the government recommends cocooning of vulnerable individuals. So it's a work in progress. We're looking at this, and some individuals we've already advised to not to come to work. They can work from home if they wish, but others will be making assessment on a case-by-case basis. So that's really what I have to say, and we'll take questions later on.
Thanks, Martin. So it's a big message there around personal responsibility, and I love that one about, you know, acting like you have the virus. That one certainly makes a lot of us think and change our actions and behaviours. Okay, so we're moving next now to Karen Egan, who's the VMware VP, and Karen is going to talk about business continuity plans, what they look like, the importance of having them. And there's some great questions coming in on Q&A. Bear with us, we will get to them. In fact, I'll go to them quite soon after we finish with the updates, because there is some great questions there. But Karen, over to you. Thank you.
Great, thanks a lot, Gillian, much appreciated. So as Gillian said, we're switching gears a little bit to talk about the business operations now, and basically, as you can see here, I'm talking about before you ever hit a crisis, that the best way to get a successful business continuity plan is to have it implemented. And really the 5 key steps are analyzing your business and designing what the continuity plan looks like. So from that analysis, what are the critical business functions? What are the scenarios that you are building business continuity for? Design what the process looks like, implement that process, but most importantly, test it on a regular basis, and then continuously review and maintain those business continuity processes, because scenarios will change, and in these unprecedented times we've just talked about, you are going to continuously need to be updating your plans. So it's all great to talk about this now, but what if you don't have a plan in place, or if you need to change your plan? It's never too late, right? And I think what I would say is, even from our own experience, we've been iterating through this process continuously over the last 3 to 4 weeks as new information has become available, and we keep abreast of what we need to do. So for me, I wanted to just highlight some areas that I think have worked really well for us in our business continuity operations. So as you're looking at your business, and even in relation to COVID-19, identify areas and look at how you're going to address them. I already talked about your business functions and the resources required, both employees and physical resources required to maintain them. Obviously, we need to look at the impact of employee absences due to sickness, or childcare needs, or other social needs of our employees during these times. Your supply chains and the impact of disruption to those supply chains, contacting your vendors, understanding their reaction to COVID-19 and what they're doing. And also the impact it's going to have on your customer requirements. So for me, it was very interesting. One of VMware's software technologies that we deliver is very focused on remote working and home working. So we're lucky we all run it today, and that technology helps us with virtual desktops running our apps on mobile phones. But now we're seeing a rapid increase in our customer needs to actually be able to deploy the software for their own BCP planning. So we're starting to see spikes in our business, and how do we revert resources to manage that? Then obviously you need to create your plans for remote working for those non-business, non-functions that can be done from home. Obviously, even in the tech sector, there's critical functions like data center functions where you are going to need to be on site, but do you need to be on site all the time as well as other things I would think about? We manage data centers remotely. Obviously, hardware replacements and all of those you need to come on site, but everything does not need to be on site. And look at the scenarios where the virus or the pandemic will impact your operations and how and what can be scaled back or suspended for a period of time to keep your business running. At the same time, you're looking at all of these business continuity plans. I think you need to take your policies and procedures into account with for your employees, as Martin talked about, for the health and safety of your employees, for the betterment of our community. So it's really important that we prepare policies on flexible and remote working and for those staff that cannot work remotely. Also looking at staggering shift times so we can have that physical stroke social distancing, not too many people in the office at one time. Make sure you're sharing policies and resources for hygiene, etiquette, and that physical distancing, and re-communicating to your employees frequently. Having frequent and effective cleaning of the workplace. So door handles, tea stations, stairs, handles, banisters, all of that really important. And provide advice to those who are infected or are suspected of being infected with COVID-19. And all of this advice should link back to the national advice and everything you heard from John, Patricia and Martin here. So we've been using gov.ie, HSE, WHO, CDC, and it really needs to link back to what the experts are telling us to do so that you're assisting your employees but using the best information available to you. And then finally, as part of putting all of these BCP plans together, in my experience, you also need a crisis management team. So when the crisis does hit, you're going to have to create new scenarios. You're going to have to look at that individual crisis and how it feeds into your BCP plan. So for us, it's really important. As a multinational, we do this on many levels. You'll have a global crisis management team, and then you'll have local teams within country and within region who can make decisions. So assigning responsibility for planning readiness to senior executives on those crisis management teams, and then establishing an authority, how you trigger the crisis management team and procedures for implementing any plans, ensuring you're meeting regularly to review and assess the situation, and also available immediately. So we have WhatsApp groups to make sure we're keeping in very close contact if anything changes in the situation and we need to make a decision. As I talked about already, following the national advice and the global advice from the experts in all your decision-making recommendations is so important in these types of areas like pandemics. And over-communicate, frequent communication and updates to your staff so they know what you're doing, what your policy changes are, and making sure you're keeping in contact with them. And even just from a social aspect, I would say we are all now working mostly from home. We've got less than 10% of people in our offices in Cork. And just having virtual coffee mornings and social communication with your team is also very important. So don't forget that aspect as well as you move into this remote working. So that's it from me. Thanks very much.
Thanks, Karen. And it's great to see technology being an enabler to help people stay social, and to talk some more on technology as enabling the workforce and in the workplace and some businesses to continue some level of continuity at this time, provide some form of service to customers. We're going to hand now to Jerry Sweeney from Cork Internet Exchange.
Thank you. Okay, Shane, am I in charge of my slides, or can you advance to the next one for me, please? So the first question that we were asked significantly from our customers was the availability of bandwidth. Would a lot of people working from home consume a lot of bandwidth? So.
Jerry, we've lost you there. You're on mute.
Thank you, Gillian. So in order to assess bandwidth requirements, the first thing we did was we looked at Italy, and this is the Milan Internet Exchange traffic. And what you can see is that there was approximately a 20 or 25% increase in bandwidth through the Milan Internet Exchange when lockdown was announced. If you can advance to the next slide, please. Okay, so we haven't seen quite the same step function in Ireland over the last week. If you look at the monthly and the yearly graph, it's actually easier to see the step function in the yearly graph, because what's happened is the day has leveled out. The traffic during the day has increased, but the spikes at night have not. And this graph is the daily graph for the last week or so. And I think the significant point here is we can see that during the day, the traffic is almost where it was at night. So traditionally, if you go back to the first Sunday there, that would be a typical day's graph where you have high traffic late in the evening. One thing that's very interesting is that on Saturday, the weather was poor, and on Sunday, the most recent Saturday, the weather was fine. And you can see a significant dip as people left the house at lunchtime and went out for the afternoon. So you can get a concept of social distancing from this. But the point that's interesting here, the point that I need to make is that peak consumption of bandwidth in this country has not increased. So what we've traditionally been doing is using bandwidth at nighttime, 9 p.m. for our Netflix, and the daily bandwidth, even with people working at home, does not exceed that peak. So for the vast majority of customers, it's not an issue. I know that for mobile phone, there has been a spike in demand, and there's been some difficulty meeting that, but I know the mobile phone companies are working on that. But in terms of bandwidth, no. Some rural ISPs that operate wirelessly have had some congestion on the last mile delivery, and I know some of those are investing in some radio equipment, but by and large, the story is good. If we can advance. Now, to create time for people to get questions, because I'm aware that we're running short on time. I'm not going to go through all of the points on this list, but what I've done is I've made two lists. One is a list of the access methods that you need to look at if you're working from home. And the other one, okay, are the security aspects that you need to apply when you're assessing which of those access methods you use. So what I'm going to recommend, because we only have a couple of minutes left and we want to get back to the questions, if you want to either see the video afterwards or take a screenshot of that, you can contact me or contact any one of your IT providers and they'll deal with that as an issue. So I'm actually going to park it there because I'm really keen that we get the questions out and go back, I think, to mostly the medical issues. Thank you very much.
Thanks, Jerry. And I know, you know, we've heard you say many times, if you can watch Netflix, then you have enough bandwidth to work from home. So it looks like we have capacity there. And if we do, God forbid, go into full lockdown at some point, it is great to know that technology is in the background supporting our ability to stay social during this time. So thank you for cutting short in order to enable the questions. We had some pre-prepared questions, but the level of questions coming in from the audience is quite high, so I'm going to jump straight to there, if that's okay with the panel. And Shane, if we could bring the panelists all on screen at the same time, that would be super. So there's a question there for John. Excellent presentation. Are we probably looking at mid to late August before we can get back to normal living?
Yeah, that's a very good question. I again would say that these are mathematical models of disease. So the the real life trajectory of this could be different. But it's interesting to see that most well-developed Northern Hemisphere governments are coming up with the same figures, that we will start to see a reduction in the number of cases in probably June, tailing probably in July. As the infection spreads throughout the community, the term herd immunity increases, i.e. people develop immunity to the disease. So those that have had the disease will have developed an antibody response to it. I know that the UK government were very heavily criticised for that. And herd immunity is a moving target, and I wouldn't be, as they say, putting my house money in it. But right now, these are the best models that we have. So yes, we'll probably see a decline in June, July, but this may change.
Okay, thanks, John. And Patricia, people are asking, does the amount of the virus that you are exposed to determine the severity of the illness you get? So if you put your hands in contact with a surface that has a high amount of the virus, does that determine your response?
So I suppose we don't really have that data. A lot of the time we're only trying to infer how somebody's exposure occurred, and we don't necessarily have the data yet on symptom severity either. We're at a relatively early stage.
Perfect, thank you. And again for you, Patricia, if someone sneezes outdoors, and this again may be impossible to answer, does the virus stay in the air for multiple hours, or can that exist in any way in the outdoors?
So it's more where it might drop. And now obviously in the outdoors, because things are happening more, it's more likely to move on. But the issue with and that's why the hand washing, I suppose, is so important, is that the virus can land somewhere, and then we know that once it lands, and I saw that was a question, it can survive for quite a long time. And so that's really the importance, and that's why we're saying every time you do go out and about, the first thing you do when you come home is wash your hands.
And I know I read in US media yesterday that the virus can last up to 72 hours on a particular surface, which is 3 days. I mean, that's very scary. Is that correct, or is that sensationalized?
It can survive for a long time, yeah.
Wow, wow. Okay, and
washing surfaces at home with Dettol, and wash, because it doesn't survive washing your hands properly. And as John explained, it needs a way to get into the body. And a lot of that time is when you touch these surfaces with your hands. So wash your hands first.
Perfect. And John, back to you again. People are wondering, does it make sense to start taking a vitamin D supplement now?
So I think that also is a very good question. So the action of vitamin D essentially is to rebalance the renin-angiotensin of the RAS system. So that effectively what you're trying to do there is trying to neutralize the amount of ACE2 that is being produced in people's cells. So if there's less ACE2 being produced, there's less chance of the virus getting into cells. We have we've no empirical data on this. This is all theoretical modeling. Based on molecular modeling. I'm taking vitamin D. I suppose the thing about the Northern Hemisphere at this time of the year, the vitamin D levels are at their lowest because we've lack of sun exposure. So anything, I suppose, that could potentially help at a population level should be looked at. So one vitamin D tablet gives you about 50% of what the recommended daily dose is, but if you've got a good diet, drinking milk, etc., you should be able to achieve that also. But there is a biochemical and molecular basis for vitamin D's effect.
Thank you very much. And Martin, you mentioned in your presentation hypertension. For the non-informed like myself, is that the same as high blood pressure? We have a question in from the floor that's asking, if I'm in my mid to late 30s and I have high blood pressure, am I one of those cases that need to be careful?
Apologies for the lingo. Yes, hypertension is high blood pressure. Okay, so the risk appears to be related to a number of factors. Okay, we're not 100% sure why, but Part of the reason may be that particularly if the hypertension is uncontrolled, that is you get an increase in the size of the ventricle or the muscle in the heart. And one of the areas that the virus appears to affect is the heart muscle as well, with a thing called a myocarditis. That might be one of the reasons why the prognosis is a little bit poorer. The second reason of here, this relates back to what John says, is that one of the treatments that is sometimes used for hypertension or high blood pressure are ACE inhibitors. And you will have heard John talk about the ACE access for the viruses into the cells. And there is at least some theory that ACE inhibitors might increase the risk, although this is really a theory and it's not proven.
Okay, thanks, Martin. And a question for anyone on the panel who'd like to take it. Are we testing for recovery in Ireland as well as infection? We see on the Johns Hopkins website that there is, infected deaths and recovery, and the recovery numbers seem to be very low. I know our chief medical scientist has said we don't give information to that website, but in general, are we testing for recovery?
When they say testing for recovery in terms of swabbing people who are recovered, we are not.
We're not. Okay.
So, there's some exceptions to that in terms of healthcare workers, but no, and there is no plan to do that. But we would be designating people as recovered, assuming that they have that 14 days and have been without a fever for 5 days.
Perfect.
So Jane, can I just pop in there? So I suppose that's absolutely correct. From an epidemiological point of view, we're not able to do that right now. We're dealing with the tsunami of infected cases, but the classical way that you look for recovery is through antibody response through an immunology test. Those tests are being developed, but we're not doing that in Ireland at the moment. We're just literally trying to identify those patients that have COVID-19 RNA on their swabs and then deal with it appropriately. And from the epidemiology globally, what we're seeing here is that these people have got to go into isolation and avoid social or physical contact. That's the most important thing. These things will come, but in an acute situation like this, we're not plastic enough to be able to respond like this. Our big problem in Ireland at the moment is being able to test patients. We have a big backlog and it's growing by the second.
Got it. Thank you. I know we're running over time, but I think the questions are important. We will run for about another 5 to 7 minutes if the panel can hold. If anybody needs to drop, we absolutely understand. If somebody in the house is awaiting test results, does everybody in the house have to self-isolate? And this is coming from a household of public service jobs. Would like to take that one?
I don't know, Martin, if you want to speak to that, because it's a bit complicated.
Okay, yeah. Okay, I'll try my best, okay? Insofar as that, because family contacts are at a much higher risk than other close contacts, the current advice is that people who are family contacts of people who are awaiting test results should quarantine. That is, they should not go to work. They don't have to necessarily self-isolate, they should quarantine. Now, that doesn't apply to close contacts, other close contacts of people awaiting test results. So people who have had, let's say, within the 2 meters, they don't necessarily have to quarantine. This is related to the likelihood of the test result being positive. At the moment, about 94% of all test results are negative. So 6% are positive. Having said that, last week 98% were negative, and probably later this week and next week, that percentage of figures that are negative is probably going to keep dropping all the time. And that advice in relation to close contacts of people waiting results may change, but at this moment in time, close family contacts should quarantine, but other close contacts need not. Patricia, would you be happy with that?
Yes, and I suppose one of the things is because of the backlog in testing, and what we've been saying is that if you're a suspect case, you really need to behave as if you are a case. And so for most people out there, we know a lot of people are already working from home, schools are closed, that's relatively straightforward. It does get more complicated if you have other people in the house, for example, who are healthcare workers, particularly if they're working in areas where there are very limited numbers, so there really aren't other people to do their jobs. And so that's really where it's important to contact your occupational health and explain through with them. But the sort of general message is, if you're a what we call a suspect case, you really need to behave as if you're a case and follow the guidance as if you're a case, because the delay now in getting a result back in some instances is up to a week. Hopefully, as the new test centres are rolled out, we'll get that time waiting period down.
Perfect. Thanks, folks. And I guess the other message is, if a member of your family believes they have it, don't automatically assume you have it, or go into this, oh, sure, we all have it now, I'm sure we're all infected and we can all relax. No, we must keep cleaning, we must keep washing our hands, we must act as if we still avoid all transmission, even within the household if possible. Jerry Sweeney, we have a question coming in there with regard to, God forbid, if we go into a full lockdown for 3 months, would service providers such as Air and KN Networks, Virgin and those, would they still be able to carry on and support what will be needed by the country?
Yeah, I'm absolutely certain that there's no problem with connectivity. We run a data center. We've decided to operate the data center with one person on site at any time, with one person monitoring remotely. We have requests to install antenna on our MAS systems next week, and we've acceded to those requests. This is to increase capacity out to rural areas. Connectivity and broadband is not a problem. It's not a slice pan or a toilet roll problem. We've got plenty of connectivity and we will be able to meet the demand, and there will be no outages. And I'm sure the same is true of electricity and other critical services as well. But in the area of broadband, I can say it categorically.
Very reassuring. Thanks, Jerry. And Karen, final question to you. Companies and businesses, they hear business continuity plan, they hear pandemic plan. What's the difference, and do we need both?
Yeah, so my opinion is your business continuity plan is something you're continuously updating, revising to make sure your operations can run under any scenario. Pandemic is one of those particular scenarios. In my opinion, yes, you need to have a scenario plan, the policies for your workforce. Lots of different things come with a pandemic outside of just your business continuity. So what we did was we created those scenario plans as part of our crisis management team, identified the policies with HR we needed to put in place, and then drove those scenarios into the business continuity planning to make sure we could continue to run our business.
Thanks, Karen. And running the business and maintaining what level of service that we can as businesses is really important. Because we're running out of time, I'm just going to mention Shane Hartigan, one of the guys in the background of this call, works for a company called IMS, and they're offering free Zoom accounts with full, features during this time, 30, 60 days with no catches. So Shane, can I invite you to come in there 1 second, really, really quickly on what you're offering companies to help them get through this time?
Yeah, no problem, guys. Thank you so much for having us this morning. Shane Hartigan, IMS. Basically, we're a company up in Limerick. We've been working with Zoom for many years now. It's now we're all in this together. Basically, anybody that wants or is stuck with video conferencing or needs to get online, go to our website. There's the website address up there, imedia.ie/Zoom setup. What we're doing is we're making available fully paid versions of Zoom to everybody that needs it during the this crisis. It's time to put on the green jersey and try and get everybody sorted out working from home, and we'll help you out with how to use it and to get to get the most out of it. And I know it's a terrible situation. It's available. Just contact us on our website, and thank you so much for having us on. We're delighted to help out with this.
Thanks, Shane, for partnering with us on this event. So this is using the webinar function of Zoom. Obviously, a lot of people are very familiar with the meeting function. It is extremely good. and we encourage people to leverage that during this time. There are lots and lots of questions that have come in. We will do our very best over the next few days to answer many of those through social media from the IT at Cork Twitter account and LinkedIn, so do tune into those. Huge thank you to our panel. We know just how busy you are, but this information has been crucial. I think to drive the message home, folks, we need to wash our hands, we need to wash our hands, we need to wash our hands. That is it. And a huge thank you to the IT at Cork team who have been organising this for a couple of weeks now. The good news is that, you know, I know these times are hard and that, but it's also in times like this that the whole world kind of bands together and gets behind these efforts, and we put all our differences aside. Great to see Ireland playing a role in both vaccine formation and in treatments. And in data collection and analysis and everything that is needed to get through this. We've also seen, you know, levels of kindness and unprecedented caring and everything, which is wonderful to see. I think at times like this as well, we get back to some of our basics and we learn what's truly important, and that is family and protecting each other. So a huge thank you for everyone for dialing in this morning in such huge numbers. Stay safe, and hopefully we'll be back to you again within a week or two with some more webinars from IT at Cork. Thank you and take care.